The NHS Long-Term Plan outlines the move to integrated care systems, ICSs. In an ICS, healthcare organisations, local authority and other partners, including third sector organisations such as hospices, take a collective responsibility for the management of resources to improve the health of the population they serve. Die Well is one of the 6 priority domains for the Alliance. Over recent years, the Alliance End of Life Board has undertaken important work to establish and increase the uptake of the My Care Choices Register. This is an electronic, palliative care coordination system. The system records end-of-life care choices for those in the last years of life or with dementia or frailty. Local knowledge and experience of care has highlighted that not everyone gets the same end-of-life care. The Accounting for Value report looked at people over the age of 18 years who were identified to be in the last 12 months of life with one of these conditions. In North East Essex, more people die in their usual place of residence than in a hospital. Over the last 10 years, the number of people who have had more than 3 emergency hospital admissions in the last 90 days of life has increased by 44%. So, how is end of life currently funded? Data was available from 4 sources: expenditure on hospital admissions, St Helena Hospice charitable funds, St Helena Hospice NHS grant funding, and Fast Track Community Care. The total expenditure was almost £40 million, with most of this money spent on hospital admissions. In the year 2018 to 2019, 250 people received a care package from the Fast Track Community Care pathway. In 43% of these cases, the cost of this package was less than a single emergency admission to hospital. By talking to those who have been involved in end of life, it was clear that avoiding admission to hospital and not dying in hospital were the outcomes that mattered. The analysis therefore focused on this and shows that if you have recorded your choices on the My Care Choices register, you are more likely to die out of hospital. People who die out of hospital are less likely to require costly emergency admissions to hospital in their last year of life. If we can encourage the use of the My Care Choices register, particularly among GPs, the potential for reinvestment is over £2 million. In 2018, a clinical audit showed that out of 100 people who died in hospital, 39% could have died out of hospital if there had been the capacity to discharge them with support. This could give a potential reinvestment of £3 million. What are the next steps? Ultimately, it is about getting it right for the individual. The main recommendation of the report is to establish an environment in which continuous value improvement, or CVI, becomes the norm. To give greater responsibility to the End of Life Board in the allocation and optimisation of resources, this will ensure the delivery of improved outcomes for local people at the end of life.